All right, so I want to welcome everybody here for today's Family Medicine Grand Rounds. Today is April the 7th, and your event code for today is 97047. And the information is there should you wish to go ahead and claim your CME credit. So please make sure you do that though before the end of the night tonight. And if you have any questions, you can either call, email, or get a hold of me as well as the CME office there. Next slide. There we go. So we want to thank everybody here in advance as we get started. If you would please mute your microphone if you have not already. We do appreciate you being attentive to our speaker today, also being engaged in our session. I would ask also, we do need your help with completing the evaluations at the end of our sessions. We have a little bit of trouble getting those returned, and we really need your help so we know we can give some good feedback to our presenters. So I'm going to be putting some information in our chat box towards the end of the session. If everybody could please help us out and fill out the evaluation for today's presenter. Next slide. And so this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central Area AHEC. And our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Those who are interested in the CME credit, you can access your transcript and view those that you have claimed credit on. But if you're having any issues with your transcript, please contact myself or the CME office. The information is listed there for you. Also, AAFP credit is available for this presentation. Any information that you need, you can contact them or myself again as well. So Staci Grant is going to be our presenter today. She has no relevant financial interest with commercial interest to disclose. And she is going to be talking to us today about addressing type 2 diabetes mellitus using the health belief model in primary care. So she is a psychology resident here with us, and she is going to be presenting for us on this topic. So I'll let her go ahead and get started.
All right. Thank you so much for that brief introduction. As I get started with presenting, I want to thank you all for this opportunity. I'm really excited, and so I'm hoping that each of you get engaged and get some really great information out of my presentation today. So I'll go through, and then any questions that anyone has, I'll help to address those at the end. Okay, so in terms of the objectives that I am hoping to get across through my presentation today, will first be to identify factors that influence adherence to treatment recommendations, to also describe how the health belief model can be used in primary care clinics, and to also demonstrate ways to implement this model in treating type 2 diabetes mellitus. Okay, all right. So first off, the health belief model. So this was a model that was developed in the 1950s by social psychologists who were working with the United States Public Health Service. It was initially developed to help examine why some individuals were failing to participate in screenings to detect disease. And specifically, it was first used in tuberculosis screenings. So as an initiative, social psychologists had put together a program to basically see, well, if we're offering these free screenings, why is no one participating? Why aren't individuals coming in? So we came up with this model, or not we, but social psychologists in general came up with this model to be able to help identify what was going on. Since then, it has been expanded to include all types of preventative actions, all types of health behaviors to ultimately prevent or reduce illness. Overall, it is used to explain or attempt to explain and predict health behaviors by ultimately focusing on those attitudes and beliefs, particular and specifically to individuals. All right. So I assume this is how it went back in the 1950s. I'm sure that there were tons of people that were around kind of saying, what are we doing wrong? What are the pieces that we're missing? But what we need is a model. We need to figure out what are the components and what are the things that we need to target to increase this health behavior. So I assume is very much like this, I'm sure. All right. So what are the components? What does the health belief model consist of? Well, first is perceived susceptibility, as well as perceived severity, perceived benefits, perceived barriers, self-efficacy, and cues to action. So I'll go through and talk a little bit about each of those components throughout my presentation, as well as touch in later on how we can address these things in our visits together. All right, so first up, perceived susceptibility. So one thing that I want to mention before I kind of jump in is that a majority of these components within the health belief model are relatively subjective. So specific to susceptibility, this is the subjective belief that a person is going to acquire some type of disease or become ill or sick. So it's their level of belief that what they're doing is either going to lead them to contract an illness or they've already gotten to the point where that's happened. One question that you can use within your visits to help yourself be able to keep an eye out or an ear for level of perceived susceptibility is trying to identify, does my patient perceive themselves to be susceptible to a particular health problem, whether that's hypertension, type 2 diabetes, any forms of illness that are coming up, all of those kinds of things. As well as, has the patient accepted their diagnosis or health condition? So let's say that you brought them in for a visit. You've already had that conversation in terms of diabetes specifically. Their A1Cs are really high. They're experiencing symptoms consistent with type 2 diabetes. But then you find they come into the next visit and it's like that conversation didn't happen, right? So maybe they've gotten to a point where they haven't accepted that. That would be a chance to be able to talk about or assess where they're at in terms of their perceived susceptibility. All right, so next is perceived severity. Again, another subjective belief, but this is more so in terms of the extent of the harm that's being done based on the illness that they've acquired. This can also be in terms of, like I mentioned earlier, just contracting the illness in general, or leaving it untreated and having a sense of how severe, what's the harm, what's the risk of even leaving those type of diseases untreated. Another question that you can use for yourself to help assess this perception or be able to get a level of understanding is to try and see how much the patient views this illness as serious. I'm just kind of outright assessing that, or by seeing how much does this illness interfere with their daily functioning. If they find that it does, then their severity might be pretty high. If they find that it doesn't, then that's another way to kind of assess where they're at in terms of perceived severity. All right, so we have these two components, right? So we have the first two, which is perceived susceptibility and perceived severity. And these two together, these two components will result in terms of the perceived threat. So how likely does the patient or the individual find this illness to be a threat to their overall health? So if the patient is high in terms of perceived susceptibility, so they're high in terms of, this runs in my family, this is something that I could contract very easily, then that rate is going to be high. But in terms of perceived severity, it's also the same way. You want them to be high in terms of how much risk they are assuming they're going to get by not changing their behavior. So both of those things will then lead to perceived threat, which again, you want this to be high in order to push them to engage in appropriate health behaviors. All right, so next is perceived benefits. So again, being a subjective belief, but this is more specific in terms of the advantages of the health behavior that's being suggested by you all in clinic, whatever type of provider they're seeing, to ultimately, they're wanting to know the advantages. Okay, well, if I engage in this behavior, is this going to reduce the severity or the harm that's being done by this illness that I have? You also want to kind of in terms of perceived benefits, have the patient identify what are the benefits to even engaging in treatment. Again, will this be effective in reducing my symptoms? That's where you want to be able to assess, are these benefits connected to the illness? And again, what is the benefit of engaging in the health behavior? All right, next is perceived barriers. These can be both perceived and they can be very real, but ultimately this is defined as obstacles to engaging in the suggested health behavior. These are identified barriers similar to the last slide with benefits, but on the opposite end, what are barriers that are standing in the way of your patient engaging in treatment in terms of following recommendations that you're making? What are things that you hear them bringing up? What do they feel is kind of standing in the way of their confidence or their ability to engage? Like I started to mention, these can be very actual or imagined. So whether it is confidence, motivation, or it's finances, transportation, the ability to even come see you, lots of those things can be identified as perceived barriers. The next piece is self-efficacy. So this goes back to being more subjective, but it is the perceived confidence that an individual has. It's their ability to engage in these health behaviors and the confidence to be able to know that what I'm doing can influence my health. It can influence the outcomes from treatment that I'm working to do, that I'm working with my PCP on. Ultimately, self-efficacy, I believe, out of any of the components within the health belief model is essential for modifying lifestyle behavior for those long-term changes specific to increasing physical exercise, quitting smoking, and eating healthier. Because as I'm sure most of you, if not all of you know, these behaviors are very long-term. It's not short-term. You can't just change one thing and find, okay, well, that increased my physical exercise, or I'll just change one thing and I'm done smoking. For some people, that might be the case, but for others, it may be that they're having to enact these changes daily for the rest of their lives. Okay, so now we're going to try to put it all together, right? So I talked a little about perceived susceptibility. I talked about perceived severity and how that leads to the perceived threat. And then we added on perceived benefits and perceived barriers. So how does this influence self-efficacy? Well, the higher perceived benefits that you have and the more likely you're able to recognize the advantages that come from health behavior change, and the less perceived barriers that you have, the more likely you're going to feel pretty confident. You're feeling nothing standing in my way. There's lots of good to come from what I'm able to do, and I'm feeling like I have that ability. So again, you want high in perceived benefits, low perceived barriers to result in high self-efficacy. So you have high self-efficacy, you have high perceived threat. What does that result in? Health behavior change. So not only you have a patient that feels that they can make change, they feel that they need to, and that's ultimately what's going to get them there. All right, so the last piece is cues to action. So tacking that on kind of at the end. Ultimately, these are prompts. They're also reminders that can set as motivation for patients to engage in health behavior change. They ultimately serve as a reminder for the severity or what is attributing to the threat of the illness that they can either acquire or that they have already acquired. They can be both internal or external. So for example, even experiencing concurrent symptoms based on their health or based on their disease, such as type 2 diabetes, experiencing any kind of fatigue, weight loss, weight gain, extreme thirst and hunger, all of those can actually be identified as cues to action. Seeing others, whether it's family members, friends, suffering from an illness can be another cue to action. Conversations initiated by you all, so by the provider. So that's why it's very important, even outside of diabetes, for smoking. When you find that patients had even mentioned and given one kind of hint, like, yeah, I want to quit one day, constantly bringing it up during your visits are cues to action. And additionally, information from the media. So whether that is ads on television, through the radio, on social media, all of those kinds of things, ads in magazines, those are all cues to action as well. All right. So we added that in. Basically, cues to action is connected directly towards health behavior change. It could be put in elsewhere, but I think that's really the most important piece, is kind of tacking it on directly to that health behavior change. Okay, so now that I was talking more broadly, I want to kind of bring it in and be more specific in terms of how does this apply to everyday things that we see in the clinic. So for example, talking about getting the influenza vaccine or any vaccine in general. So you have some of these things might be phrases or things patients might say, and they might tell themselves in relation to wanting to get the vaccine. So in terms of perceived susceptibility, so right here at the top, I'm not sure if you guys can see my mouse, but you might hear a patient say, it is likely that I'll get the flu. Like it happens every year, so their perceived susceptibility is fairly high. In terms of perceived severity, how bad would it be if I got the flu? So just by that statement alone, you can't really identify whether it's high or it's low, but if you hear your patient say this, at least you know they're thinking about it. They're thinking about what could come, whether or not I get it or I don't. In terms of perceived benefits, getting the flu vaccine will prevent me from missing work. Okay, so they've identified I'd rather have the vaccine and not miss work rather than get sick and then end up missing a lot of time. In terms of perceived barriers, I'm afraid of potential side effects from getting the vaccine. I'm sure this has been several things you probably all can resonate with in terms of things that your patients have said. So both of these, in terms of the perceived susceptibility and perceived severity, result in the belief of in the threat that they're going to get the flu. Again, this doesn't really tell you whether it's high or low perceived threat, but the patient is at least considering what could come out of me not getting the vaccine. And then in terms of self-efficacy, I'm confident I can get the vaccine at my doctor's office. So they've reduced barriers, they've identified benefits, and that's resulting in an increased self-efficacy. So they know where to get access, they know why they should, all those kinds of things result in that component. So both of those things together will then ultimately tell you or your patient whether or not they're going to get the vaccine. Also, by adding in cues to action down here at the bottom. So whether it's seeing others getting the vaccine, whether it is, a medical assistant, a nurse, a PCP, anybody that's part of the team really popping in and saying like, hey, did you get your vaccine today? Have you gotten the flu? Do you want to get it today? Those are cues to action. All right. So one thing I want to do just to give more clarity in terms of how to apply this in everyday visits is to talk a little bit about a patient that I had actually worked with and see how he fits within this model. So I'm going to go back just one slide to be able to give you guys context, but I worked with a patient that was in his late 40s. We'll just call him John Doe. And he's already diagnosed with type 2 diabetes, and he received a below the knee amputation. So I'm sure most of you are thinking, yeah, that's pretty consistent with patients we see at the Family Health Center. And for some of you, maybe even thinking ahead, perceived severity and maybe perceived susceptibility are pretty high in this patient, right? Not the case. So in kind of thinking about readiness for change. So how we can get him to start improving his health or to either delay or to decrease the trajectory of his type 2 diabetes. I tried to really kind of dive into a couple of these within my visit with him. So he was reporting they didn't have a whole lot of social support. His relationships with his family, specifically his wife and his children, were not great. Following his amputation, he didn't have a whole lot of confidence or ability to do things on his own. But oddly enough, his severity was very low. So perceived susceptibility was high because of the risks and consequences of his health and of his behaviors. But in terms of perceived severity, he was still engaging in unhealthy eating. He was drinking a lot of sweet tea. He wasn't necessarily taking his medications as prescribed. And the perceived threat was also very low. So he didn't have much drive to want to engage in any of the recommendations that either myself or his PCP were making. It was hard for him to identify any benefits from change, and his barriers were very high. He wasn't independent in terms of making his own foods. He, again, didn't have that social support from family, and so his self-efficacy was low. So understandably, if your perceived threat is low, your self-efficacy is low based on what we had talked about a little before, your health behavior change and willingness to engage is not going to be high. But cues to action, so continuing to bring up reasons for why he might want to change. So highlighting those things in visits, as I'll talk about a little later, were definitely things to continue doing from visit to visit. Okay, so now that we've talked through those examples, I want to, let's see. I'm hoping this will work, but maybe if we could just use the chat box. I was trying to use poll everywhere and I'm not quite sure how to start it, which is my fault. But in terms of the health belief model in action, I wanted to be able to give you guys a couple of statements that you may hear from your patients and see if we have a good sense of what category that might fall into. So let's see. I'm just going to go ahead and pull up my the chat box for those who want to participate. Have kind of type in what category you think the statement will fall under. All right. So for the first one, let's say that your patient tells you, "I don't have time to watch what I eat," and this is specific to type 2 diabetes. What all category do you think that statement might fall under? I don't have time to watch what I eat. Yep. Yeah, right. So a perceived barrier. Patients at this point is just not willing. That's something that they find to be standing in their way. Great job. Awesome. What about if you heard a patient say, "I am afraid I will start to lose my eyesight or feeling in my hands and feet"? Any thoughts on what category? Yeah, perceived severity. Awesome, right? Because patients are starting to identify the risk and consequences of their behavior. Great. What about "My father has type 2 diabetes, so I am sure I will be diagnosed eventually"? Yep, susceptibility. Awesome. Yep, definitely. Let's see. "By reducing my sugar intake for my type 2 diabetes, I will also lose weight." Benefits. And "My father-in-law passed away as a result of not managing his type 2 diabetes." This might be a tough one. So I'm here. Yeah, threat. Yeah, because the threat's real, right? It's very personal. It's personalized to what the patient is reporting. Exactly. What is the other one? "I can take my medication as prescribed." Self-efficacy. Yeah, you guys are right on the money. This is great. And last, which I'm sure this is kind of a giveaway, so everyone should get it. Increase thirst and or hunger, checking blood sugars. Yeah, or even seeing other people managing their health. All of those things can be considered to be cues. Great job. Thank you all. I appreciate your engagement in that. Hopefully that was somewhat entertaining. All right, next I'm going to talk about facilitators and barriers to medication adherence. So I'm going to highlight a couple of things. So based on prior literature, a majority of the top facilitators to adherence that I've seen most often are social support, acquired knowledge, and self-efficacy. So I'm sure you all are thinking like, "Oh, I've heard that term before." Well, it's in the health belief model, right? So specifically in terms of self-efficacy, there's general and there's health specific. So confidence in terms of all behaviors or specific to your health. So in terms of those facilitators, you'll find that increased social support, knowledge specific to the patient's condition, and increased self-efficacy. All of those things together or individually can result in greater adherence to treatment. So what I all want you to do in terms of what do you find to be helpful in increasing your patient's adherence? I started the presentation, so I'm wondering why it's not working. Technical error. But I guess if you all want to use the chat box again, I can kind of check on those. I was trying to do a word cloud and I'm not sure why it's not working. Encouragement and follow-up visits. That's a great one. Any other thoughts? So any other things you've heard patients say that are really helpful? Yeah, so using pill boxes, so giving them more of a strategy to be able to be consistent with their medication. Involving the spouse, involving family. Yeah. Eliciting confidence, cueing the risk. Yep. Yeah, so those are great. Education. I think education is a really big one. That can be a great facilitator. Awesome. Yeah, using reminders, asking about barriers. Perfect. Yeah, so helping them to reduce those. Those are perfect in terms of definitely in line with the health belief model and definitely things that can be helpful for patients. Great. All right, so next we're going to touch on barriers. So based on prior literature and a lot of things that I've seen out there, perceived stress, depressive symptoms, and perceived severity. So I'm hoping all of your feelers are kind of going up because that term may sound familiar, right? Again, part of the health belief model. So specifically, greater perceived stress, moderate to severe depression, and low perceived severity. So all of those things together, ultimately or individually, will result in poorer treatment outcomes. So again, a little bit of engagement here. What other barriers have your patients mentioned during visits? I know we've talked about a little, but what are some ones that you have heard that have come up from your patients? And please feel free to jump in the chat as I'm not sure why it's not working. Financial issues. That's a huge one. I don't have time. I hear that a lot. No time. Yeah. Forgetfulness. That's a big one. I have bigger problems at home. Can't get refills easily. Trouble with insurance. Oh, that is huge. And that's a very real and a very actual barrier. Yeah. Time consuming. Logistical, no transportation, no place to work out. So not really like a safe environment. Too many pills. Side effects. Yeah. And those are definitely ones that you hear about during almost every visit. And it's very, like I mentioned, very real for our patients. Thank you, guys. Okay, so now that I've given you all this information, you're all probably thinking, okay, well, what do I do with it? How do I use this information, knowing about facilitators, knowing about barriers, about the health belief model? What does that mean for me and how I work with my patients? Well, first, we'll talk a little bit about perceived susceptibility. So how does that come up in my visits? How do I use that component to be able to motivate and assess readiness in terms of my patients? Well, for susceptibility, you'll first want to, and with all of these components, really assess where your patient's coming from. What are their current perceptions in terms of their health? Once you've done that, then you can move to frame your recommendations accordingly. If you find that their susceptibility is fairly low, You may recommend some education, recommend assessing their family history, really talking to them about their risk, and highlighting, as I jump to the next point, highlighting symptoms related to the disease. They may already be experiencing symptoms and don't realize that they are symptoms of type 2 diabetes, right? So that if they start mentioning increased thirst and or hunger, fatigue, frequent urination, some of those things patients may not realize those are actual symptoms of type 2 diabetes. So even just highlighting those symptoms gives them more of a perception that like, oh, all of these things are symptoms. I had no idea. Maybe my risk is a lot higher, or my perceived severity, as I jump to next, should actually be a lot higher because I didn't realize that all of these things were connected. So in terms of trying to increase perceived severity in our patients, working to specify consequences and risks of the condition, right? So not only of the condition, but of their behaviors. So in the long term, what are the things that are going to could occur in terms of them contracting or developing type 2 diabetes? So specifically, kidney failure, diabetic neuropathy, diabetic cataract, and even amputation. So really telling them, like, if you don't address these things, if you don't change your behavior, this could be possible. So again, personalizing their risk based on what they're currently doing. So highlighting what they're doing, how that's connected to risk, can be a good segue into increasing their perceived severity. All right, perceived benefits. So one big thing is to define actions that they can take here and now, right? So by targeting other types of health behaviors related to type 2 diabetes, they can kind of get, a 2-for-1, right? So the biggest bang for their buck. So talking to them about how weight management, so addressing their eating behaviors, addressing their physical exercise and physical activity. How can weight management ultimately impact type 2 diabetes management, right? Addressing high blood pressure. Again, how are those two things connected and how can they ultimately address both at the same time? Attending medical appointments. What's the point of that, right? So highlighting the benefits to consistently coming in for their appointments, to taking their medication as prescribed, and to really addressing all of their health. Clarifying positive effects of action. So again, touching on all of those things, and if by basic clarifying it, laying it out very clearly for them, if you engage in ABC, these could be the potential outcomes. And also trying to incorporate these benefits as reinforcers for behavior change. So the more that you engage in exercise and changing your diet, the more weight you'll lose and the better you'll feel. And ultimately your type 2 diabetes will be addressed as well. So really making it bigger picture and giving them an end to how all of those things are connected. Additionally, perceived barriers. So I think some of you had already kind of mentioned this in the chat box in terms of the barriers that you've heard in working with your patients. And so that's fantastic. I think that we're all, on the same page in terms of these potential components to address. But ultimately, collaboratively discussing how can you reduce and overcome these perceived barriers, specifically in terms of forgetfulness. So that's one that I heard. Finances, another one, transportation, and treatment burden. So more oftentimes than not, especially with type 2 diabetes, treatment burden is especially high. So being able to identify what part of the treatment is bringing on so much burden. How can we work to address a specific piece, whether it's emotional burden, physician burden? Do you have good rapport with your patient? Do they have the social support that they need? Being able to really address each piece and work to say, okay, well, how can we work together to be able to address these barriers? Ultimately, that results in some problem solving or just providing reassurance, validating the patient and letting them know, like, hey, I hear you. This is really difficult, but how can we work together to be able to address your health? All right, cues to action. ultimately eliciting potential cues from patients to help them serve as reminders for what they're currently doing is to help them identify, I'm doing these things and these are consequences for my type 2 diabetes. Instances of fatigue, weight gain, like I had mentioned earlier, excessive thirst, hunger, change to their eyesight. All of those things can be cues to action. I feel like these two that I mentioned here are most are ones that we can target early on. So if they start to feel relatively sluggish, they've been gaining some weight, how can we jump in early to be able to address these things? And how can we make those cues to action for type 2 diabetes? Again, kind of jumping back to even perceived susceptibility and severity, highlighting what are the risks and consequences and how can these symptoms further exacerbate to increase risk of type 2 diabetes. Additionally, just promoting awareness and education. So using pamphlets, visuals, videos are huge. And even just giving patients information to say like, here, take this home, read it over if you'd like, to be able to get a better sense of what is type 2 diabetes. Some people don't even know. A lot of patients seem to benefit a lot from learning more about their health. Which falls perfectly in line with the facilitator I talked about earlier in terms of knowledge, right? And last but not least, if there's anything that you take from my talk today, cue really fancy transition, is utilizing additional providers to help educate patients. So this is my plug for behavioral health consultants. So really using your BHCs if you have any in your clinic, using your nurses, pharmacists, any other provider, medical assistants. Each part of the team plays a huge role, and there's so many opportunities for education. So really relying on other providers and team members to help you take this all on. And last but not least, self-efficacy. So how can we do that? How can we increase self-efficacy in our patients? Well, for starters, is increasing perceived benefits. So really highlighting those pros, highlighting what you hear in your visits, highlighting the advantages that you find your patients are identifying, and trying to work to reduce perceived barriers. So those are the big targets: is being able to highlight those pros and help them reduce those barriers. So if anything, cues to action, utilizing additional providers and self-efficacy are huge and big takeaways. So I'm sure you're all thinking, okay, this is great, but I only have 15 minutes. How am I supposed to do all of this in such a short amount of time? Well, in terms of those things, like I had mentioned, really picking out just certain components, maybe trying to assess perceived susceptibility in one visit, and then the next really moving to perceived benefits, maybe even trying to sprinkle in some cues to action every now and then, and overall really trying to help increase that self-efficacy. Any part of the health belief model can be used within any part of your visit. So lastly, I want to kind of talk through more application. So how is this seen kind of elsewhere in the world? How is this applied? So I wanted to talk through an article. Basically, it's was developed by Cronin et al. In 2018. And unfortunately, it's not specific to type 2 diabetes, but a lot of things that they talked about in terms of their article not only extends the health belief model, so adds in other vital components, but talks about missed clinic appointments, which I feel like comes up a lot at the Family Health Center, as well as probably other clinics in the surrounding areas. So within the article, Cronin et al. Had surveyed adults and caregivers of children with sickle cell disease. So 87% of adults reported missing clinic appointments. 65% of caregivers of children also reported missing clinic appointments. So within their article, they use those components of the health belief model that I had reviewed early on today, and they also added in social determinants of health. So they assessed for age, race, ethnicity, level of education, marital status, all things that make a person who they are, right? They also had assessed depressive symptoms, which again, I'm hoping maybe some of your feelers are going up because I identified that as a barrier, right? So keeping that kind of in the back of your mind. Social support, a facilitator, health literacy, again, kind of falling in terms of facilitator, like all of these things are connected, right? So how can we increase knowledge? How can we have that play a role in terms of our patients? And lastly, spirituality, which I found to be really interesting. So again, they extended the health belief model, really assessed for all of those perceptions, self-efficacy, cues to action, and then they added in these components as well. And what they found was that big surprise, which I'm sure not a whole lot of you are maybe surprised, but forgetfulness was the most common reason for missing appointments. That seems pretty explanatory, right? Pretty common. Additionally, lower spirituality was also associated with attending appointments. Kind of interesting, food for thought. I thought it was in kind of reflecting a little bit back on it, spirituality could be perceived as a barrier, or it could be perceived as a benefit. So whatever it is that the patient reports when they're talking to you. So you could be able to use spirituality, other specifics that make the patient who they are, individualized in terms of your approach to treatment. Is something to consider. So one may not think like, oh, spirituality is a great place to start, but it's definitely one thing that you can bring into your treatment. In adults specifically, health literacy, so low health literacy specifically, financial insecurity, and age were significantly associated with missed appointments. So all of those things that we had highlighted early on, all of those things we had talked about in terms of barriers, literature, it's all kind of coming up, right? And it's seen very much in our community. Okay, well, ultimately, summary of my main points from my presentation today, just to review briefly, is that the health belief model can be used to explain and predict health behaviors and preventative action. So really can be used in any context within your visits. Facilitators and barriers to adherence can vary from patient to patient and can be very much individualized. Any component of the health belief model can be used within any part of your visit or across visits to address readiness for change, like I mentioned earlier. And again, my second plug and my big takeaway from today is to use your team members, rely on one another to educate patients, reduce barriers, and increase access to care. So that wraps up my presentation for today. I hope you guys took a lot out of it. And if you have any questions or comments, I'd be more than happy to answer.
I think there are a few questions here in the comments section. I know that one of our doctors is asking if they can have access to the PowerPoint slide, so I will leave that up to you. If so, I'm happy to help with that part.
Sure, yeah, no, I'd be glad to share.
Okay.
Yeah.
And then there are some other questions in there. I don't know if you have your chat pulled up, I guess.
Yeah, I do.
Okay.
I don't mind reading them.
Okay.
Yeah. So let's see. One comment is, what implementation tactics work within a primary care revenue stream? Screening, support groups, outreach, nurse educators. Yes to all. I think that they're all great tactics that could work within primary care. I think a big one that I haven't actually had the opportunity to do much of this year are definitely groups related to care, so to diabetes management. I think that could be a big takeaway, because not only is that bringing in cues to action, but it's also kind of helping address some of the perceived threat and self-efficacy. So if you find that other people are experiencing similar symptoms to you and seeing how you manage it, it can spark some motivation and readiness for change in yourself or in your patients in particular. Yep. Social determinants includes food insecurity, definitely, housing, social isolation, transportation, and income. Yes. So all of those things are definitely included, but specific to the article that I had referenced there at the end, those were the only social determinants of health that they had assessed and looked at. But again, further studies, I'm sure that there's other studies out there that probably look at those as well. How could the health belief model be used to better understand or increase COVID vaccine uptake? Great question. And I think even talking back with the influenza vaccine example that I gave can be easily applied to COVID. However, in terms of the perceived barriers, perceived susceptibility, given everything that's going on, different views on education related to the disease and the pandemic, I think there's several factors that are playing a role. And one thing that I think any provider can do is provide a lot of education, a lot of support, reassurance related to each component of the health belief model to either promote self-efficacy or to promote that perceived threat. And if there are a lot of perceived barriers, which I know that there are a ton, especially in a variety of our patients, specific to gender, age, race, ethnicity, all of those things play a role. And so being able to consider those as well in terms of the health belief model, those are great, and I think are definitely much needed and very vital to using that for COVID vaccine uptake. You're very welcome.
Do we have anybody that would like to unmute or comment?
Thank you all so much. I appreciate your engagement and your time. I really enjoyed this. I hope you guys were able to take away some great information today.
Well, with that, we will go ahead and close the presentation. Thank you so much for giving your presentation today. If everyone could please, I put the link in the chat box again. Please make sure to give her our feedback, and I will make sure anybody who wants those slides, I will go ahead and provide for you. But thank you again so much. Thank you, everybody.
Thank you.